Great, thanks for the nice introduction. And also, I was looking at the audience list. Great to see a lot of familiar names out there. So thank you for joining. And for those I don't know, thank you for joining. I'm going to be talking today about myeloma frontline therapy and also kind of the myeloma 101 talk. A lot of this will be, old news to many of you, but I hope that even if that's the case, there's some new kernel of knowledge everyone can take away. So can we go to the next slide, please? So these are my disclosures. I'll just leave this here for a second. All right, please, next slide. Okay, so the goals, first of all, kind of going over again the basics of multiple myeloma. What is this disease? Why does it matter? How common is it? How do we diagnose it? And then talk about what kind of treatments we can give for patients that have a new diagnosis of multiple myeloma. And that is an area that is really evolving so rapidly such that, by the time I finish this talk, some of what I said may be outdated. Reviewing data on autologous stem cell transplant, also a very important part, we still think, even in 2021, for myeloma therapy. And then reviewing standards for maintenance therapy in myeloma. And before I start, I also just want to mention, we had a big loss in the Fred Hutch community. Dr. Eli Esty, who's one of the leukemia doctors here, who's very well known, passed away last night. And I just wanted to mention that. So I know this is a myeloma meeting, but he was really a giant in oncology, and it's such a tragic loss. So anyways, I just had to say something. So let's move to the next slide. So what is multiple myeloma? Multiple myeloma is a plasma cell neoplasm. What is a plasma cell neoplasm? I think it's important when we think about any kind of cancer, it is always, what is the cell that the cancer comes from? And, so why it's important in multiple myeloma is not only is it important for understanding the disease and how it affects people, but it's really important for designing therapies. When we understand the biology of the malignant cell, we can really better understand what its Achilles heels are and how we can target the cell. And so this stuff is really important to scientists, to biologists, to translational researchers, and to clinical researchers like myself. So myeloma is characterized by proliferation of malignant plasma cells. And, what causes this, we don't fully understand. And this is unfortunately a common thread with most malignancies. The best example of a cancer where we know there's a clear link between exposure and development of the malignancy is lung cancer, and smoking rather, or bladder cancer and smoking, or certain exposures to radiation and development of things like thyroid cancer. But with multiple myeloma, there's not really, there's associations. For example, folks who work in agriculture, first responders to 9/11, firefighters, these are all occupations or exposures that are associated with higher risk of multiple myeloma. But we don't know exactly what about that, leads to developing myeloma. What happens in this disease is that you get a clonal population of the plasma cells that produce excessive amounts of antibodies. These are the antibodies that help us fight off viruses, bacteria, except in this disease, we have too much of it. And that's the M spike, the monoclonal immunoglobulin. We also see production of cytokines and other factors that interfere with bone metabolism. We see overproduction of light chains that lead to kidney failure, suppression of normal hematopoiesis or production of red blood cells, and also reduced immunity. Immune dysregulation is really the key. One common thing I've seen before people develop myeloma is they have a history of recurrent episode of shingles. That seems to be a common, when I ask folks, it's a common thread. Why? I think it just highlights this immune dysregulation. And certainly shingles is common in older people, and most people are with myeloma are over 50, but it does seem to be more common. So immune dysregulation is key. Next slide, please. So this just highlights, this is a slide that shows hematopoiesis. So what is hematopoiesis? It's the production of your immune system, your red blood cells, all of the parts, all the components of your blood from a single stem cell. And these stem cells are useful for stem cell transplant. These are the stem cells we use. They have the capacity to produce all the lineages of our immune system: platelets, erythrocytes, dendritic cells, macrophages, neutrophils. Everything can be produced by it. And you see here over on the top, the development of the stem cells into different differentiated cells that ultimately result in production of a plasma cell. Next slide. So I'm just kind of in this following slides going to go through the different tests that we obtain to diagnose someone with multiple myeloma. So what is an M spike? That's the first question, because your doctor will commonly talk to you about an M spike. The M spike is the measurement of the immunoglobulin molecule. What is the immunoglobulin molecule? That's shown here. It's an antibody. Antibodies are produced by plasma cells, and they're produced in response to either a foreign object or more commonly an infection. So when you get infected with a virus or a bacteria, what happens first is your plasmablasts rev up, and they proliferate very quickly and produce huge amounts of antibodies. And these antibodies neutralize viruses and bacteria. This is such an important part of our immune system. And so this is what an antibody looks like. They have very high binding capacity to viruses, bacteria, or whatever the protein is that they target. There's 5 different types of antibodies: IgG, IgM, IgA, IgD, and IgE, and they all serve slightly different functions. One thing that's, kind of following from how I mentioned that the biology is important to understand, each of these antibodies has slightly different properties. IgM is a big molecule. So if we have too much of it, it can cause something called hyperviscosity. Patients with IgG versus IgA have slightly different presentations. So these can be important, and they're also important because usually when you have one of these antibodies or monoclonal proteins identified, it's usually always going to be the same one identified when the disease comes back. More on that later. So next slide, please. The SPep is how we identify the plasma cells. Sorry, I'm just going to stop my video for a second because I think I have a bad connection here. All right, looks like I'm back. I'm good. So SPep is a way to quantify how much immunoglobulin we have. And an SPep is basically an electrophoresis gel that separates out proteins by their charge and size. And this is what a normal SPep is shown in blue. And the peaks basically show the density at a specific site. So albumin is a common protein in the blood. Alpha-1, alpha-2, beta, and gamma. The gamma region is where we find the M protein. And if we see a spike in the gamma region, that's indicative of a monoclonal protein. Next slide, please. So one other thing I should mention about the SPep is just a way to quantify how much M protein we have. The immunofixation is the other really key test, and that is how we identify which monoclonal protein it is: IgG, IgA, and then also the associated free light chain. And so that's a nice segue to talking about a free light chain. So what the heck is a free light chain? Serum free light chains are part of the immunoglobulin molecule. They attach to the heavy chains, which are the inside portion that's longer. They're produced on a separate chromosome, and they're actually produced independently, and they're made into immunoglobulin molecules inside the plasma cells and secreted. But one thing that happens in multiple myeloma is these serum-free light chains are overproduced. And that is one factor that can lead to kidney failure in multiple myeloma. There's only 2 flavors of free light chains. There's kappa and there's lambda. And they're measured by an assay called the serum-free light chain assay. So one thing that's very important when we're testing for multiple myeloma at the time of diagnosis, serum-free light chains have to be done at the time of diagnosis. They also have to be done when people are followed with their disease. Something I've seen even nowadays is that some doctors will only follow the M protein not the free light chains. It's very important to always get both, because a free light chain that's above 80 milligram per deciliter or so is associated with a very high risk of renal failure. And that's considered something that would be sort of a urgent indication to start treatment for most patients. Next slide, please. So how common is multiple myeloma? It is the second most common blood cancer in the United States, the 14th most common cancer overall. It is the incidence, which is an epidemiologic term that means how often it gets diagnosed per unit population, is about 7.1 rather folks per 100,000 people per year in the United States. There'll be about 34,000 cases in 2021. It's only 2% of all cancer deaths. Far few people are dying of multiple myeloma that are getting diagnosed. And the number of people alive with the disease continues to grow, which I think really speaks to how effective treatments are at keeping people going. I had a very interesting conversation just to highlight this recently with Dr. Tom Lynch, who's the head of Fred Hutch. And we were talking about myeloma, and he's been an oncologist for a long time. And one thing he said to me, which really struck me, and we hear about this all the time, he said, when I was in fellowship, the lifespan of multiple myeloma patients was 2 years, always 2 years. Everyone got melphalan and prednisone, and no one lived more than 2 years. So the fact that we have patients, and we'll get to this later, that are living 10, sometimes 15 years with the disease is really, to me, incredible, and really highlights how much the science and research has helped improve the outlook. Next slide, please. How does myeloma present? So these are some of the symptoms folks can present with. Anemia, very common. Most patients will present with anemia. That just refers to having a low red blood cell count. Bone pain. The most common reason for bone pain is a fracture. What causes fractures in myeloma? The bone gets weakened because of excessive production of bone turnover proteins, but also because of these lytic lesions. The lytic lesions are areas where the bone is being eaten away, often by a tumor, sometimes by what we would call that a plasmacytoma. Elevated creatinine is common. That's due to the free light chains. We call that myeloma cast nephropathy. And then high calcium, which is caused in part by bone turnover. Next slide, please. Here are the CRAB criteria, and this is a mnemonic doctors use to remember the key features of multiple myeloma. So you will sometimes hear this. Next slide. The diagnostic criteria for multiple myeloma are shown here. This has been the most recent iteration since 2014. So in order to get diagnosed with multiple myeloma, you have to have bone marrow plasma cells over 10%, or a biopsy-proven plasmacytoma plus the CRAB criteria, which we've talked about. There are some other features that are considered consistent with myeloma that were introduced in 2014 and are now part of our regular practice, having a high serum free light chain involved to uninvolved ratio, greater than 100, one or more focal lesions on bone marrow MRI, and greater than 60% clonal plasma cells in bone marrow examination. So it's possible someone could get diagnosed with multiple myeloma and have none of the CRAB features, and your oncologist might recommend starting treatment. And that can be kind of a tough pill to swallow, but I would say, it's a good thing to catch it early. People who have these features, almost all of them end up developing multiple myeloma or needing to start treatment in the next year. So really, I really like to think of these biomarker-driven criteria as a way to treat the disease before something bad happens. And so that's why I really think these are so important. And there may be others that get added in the future. We are learning a lot about this disease constantly, and what kind of factors predispose people who have the precursor condition, smoldering myeloma, to getting myeloma more quickly. Next slide, please. So I just want to review quickly some of the imaging modality tests that we can do. Bone marrow MRI was mentioned. This is a test that your doctor may order. MRI is more sensitive for detection of bone involvement than a skeletal survey. The skeletal survey, which is all the x-rays, we call it an osseous survey, that is a really outdated study. I should have included a slide here, but I didn't have enough time on whole body CT. And I think it's worth a mention. Whole body low dose CT is rapidly replacing the skeletal survey as an imaging modality for detection of lytic lesions. In my opinion, there's really no reason to do an osseous survey nowadays unless it's, we're in a resource limited setting and we can't get it, or it's something we can get on that day quickly. But an skeletal survey with a CT would still be indicated. MRI is important, but it's important to know that it doesn't really show, so we have in our bone, we have two parts. We have the cortex, which is the hard part, and then the inside, which is the medulla or the marrow, and that's where the bone marrow forming elements are. And what MRI can show is those soft tissue lesions inside of there. MRI is also really good at detecting spinal cord compression, so that's something CT is not quite as good at. MRI is also less helpful for determining response to therapy. So next slide, please. So PET-CT is really, I think, one of the most important, in my opinion, modalities we have to monitor treatment and also for diagnosis. PET-CT combines two modalities. We have a PET, that's a nuclear imaging study. That's a test where we give you a tracer, and then we take a picture with a camera that can show where the tracer localizes to. And the tracer goes to spots that are growing quickly, like cancer. So we fuse that with a CT. So kind of like the low dose whole body CT we do for lytic lesions, we can do that with a PET CT, and we fuse it together and we get a picture that shows not only if there's destruction of the bone, but also if there's activity. So the PET CT is a really important modality. It's one that I really prefer at diagnosis and then for monitoring response to treatment. Next slide, please. So the other important test we get at the time of diagnosis is a bone marrow biopsy. A bone marrow biopsy is a procedure where we take a needle, we stick it into the hip bone, the iliac crest, and we take out not only a sample of the bone, a small sliver of the bone, but also some of the liquid bone marrow. And that's really, really critical. Even if you had a tumor and they stuck a needle in it and they said it's a plasmacytoma and they otherwise thought you had myeloma, you still got to get the bone marrow biopsy. And because the bone marrow biopsy is where we get not only the flow cytometry, but tells us if there's an abnormal plasma cell population, but also the FISH. What is FISH? FISH is short for fluorescent in situ hybridization. It is a test where we look for chromosomal changes in multiple myeloma. Think of this as a type of genetic testing, looking for changes in the genes. And there are certain changes that are associated with poor outcomes, and we call that high risk. And so you'll hear your doctor talk a lot about high-risk myeloma, and the ones that are considered high risk are 414 translocation, which is the third one, and del17p. The other ones that aren't listed here are translocation 1416 and translocation 1420. And so these are really important to know. Sometimes they might change what we might recommend for treatment. Next slide, please. So another way to look at prognosis in multiple myeloma is the revised international staging system. And the way we stage myeloma is shown here. It's different from like staging for breast cancer or colon cancer, where we look at the anatomic spread. So we look at where the lymph nodes are. This is more about prognosis. So we know that the patients with stage 3 myeloma tend to have a more aggressive disease course than the patients with stage 1. And so the scoring system is shown here. I'm not going to go over it, but you guys can look at this in more detail on my slides later if you wish. Next slide, please. So again, this is talking a little bit about high-risk myeloma, and I harp on this a lot because this is really where we need to see the most progress. People with standard risk myeloma, this disease is these are the patients that often live with this disease for 10, 15, even 20 years. High-risk myeloma is a different disease. It's more aggressive. The treatments work, but they don't work for as long. it's about 20-25% of patients who have myeloma. And so we really need new strategies to try to figure out who the high-risk patients are, because even our current systems aren't perfect, and get better treatments for them that can overcome the nature of the tumor to be more aggressive. Next slide, please. So here is a depiction of one potential way of thinking about how we treat multiple myeloma. I'm going to go into some of this in the slides to come. This is not going to be an exhaustive talk, but I really just want to kind of highlight some of the key advances over the past few years, and also, what the standards are. So for a patient that's eligible for a stem cell transplant, we would start out with 3 or 4 drug combinations, including a proteasome inhibitor like Velcade or Carfilzemib, an IMiD like Revlimid, or a CD38 antibody like Daratumumab, or another one that's now approved is Isatuximab. Autologous stem cell transplant, which is a procedure where we give high-dose chemo followed by reinfusion of stem cells, is I think most in myeloma specialists in the US would still recommend that. Even though these new drugs are very effective, the transplant increases the depth of response and how long people stay in remission. And then after transplant, we recommend maintenance for all patients. And maintenance is, the idea is just, we're giving a treatment that would help keep the myeloma under control for longer, but a lower dose, so better tolerated for the most part. For patients who aren't eligible for transplant, we generally recommend 2 or 3 drug combinations like the above, but without the transplant. So you just go straight to maintenance. And then supportive care, which includes things like drugs for prevention of infection, prevention of blood clots, and reduced risk of fractures, we would generally recommend a bisphosphonate. Next slide, please. So I'm going to skip over this because I've taken a little bit too much time. So let's go to the next slide. So here's a list of the approved drugs in multiple myeloma. And I really showed this just so you can get a sense of how much this has changed. If you had shown this slide like maybe 30 years ago, you would have just seen melphalan and prednisone. And again, everyone lived 2 years. And so this is really speaks to how much the science and clinical research and investment from, not only the NIH, but also from biopharma has really helped to accelerate the treatments that are available for patients. And I put in red the ones that have been approved this year. So already, well, over the past year, these 3 drugs, belantamab mafodotin, which is a BCMA antibody drug conjugate, melflufen, which is an alkylator, and idacabtagene viclucil, which is a BCMA CAR-T, are now approved. And we may even have another CAR-T approved for multiple myeloma later this year. More to come on that. Next slide, please. So a couple of things that I just want to update everyone on. So the standard induction, we would start with Revlimid, Velcade, and dexamethasone. For many years, there was a debate in the myeloma community about Carfilzemib, Revlimid, and dexamethasone. Carfilzemib is another proteasome inhibitor. And for many years, people said there were those who thought that Carfilzemib might be better. So this was a study that compared RVD to KRD, and this was run by a cooperative group study. This is a cooperative group trial, so that means it's funded by the US government. It's rolled out to not just academic centers, but community centers. And so patients were randomized to get RVD or KRD, and then subsequently randomized to get RVD maintenance at 15 milligrams for 24 cycles, or indefinite Revlimid maintenance. Next slide, please. Interestingly, that study did not show a difference between RVD and KRD. Unsurprisingly, they did see that there was more neuropathy with RVD, which is not shocking to me, and slightly more cardiovascular events and renal failure with KRD. But overall, in terms of their efficacy at getting the myeloma in remission and keeping it there, they're pretty similar. So I think there may be other studies looking at this that could change how we think about this, but for now I would consider them roughly equivalent. And this would also give one some impetus to choose KRD for a patient who, say, had neuropathy already and couldn't get RVD. It's at least as good as RVD. Next slide, please. So what else is hot and new in myeloma? The other thing you might be hearing a lot about is 4 drugs. So that's the idea of adding Daratumumab, a CD38 antibody, to the upfront treatment of myeloma. One of the studies that was done in the US was the Griffin study, which was a randomized phase 2 study of Dara RVD versus RVD for patients who were eligible for transplant. And basically, this is a schema of the study, and it shows kind of how patients were treated as they went on the study. Next slide, please. This study did actually meet its primary endpoint. The primary endpoint is, what that means is they designed the study to answer a statistical question. In this case, what percentage of patients have a stringent CR after getting consolidation? And for the study, they showed that there was a higher percentage of patients who had a stringent CR who got Daratumumab. And so, there do seem to be quite deeper responses, more MRD negative responses. And so this is evolving, but this is something that I think, in many parts of the country, myeloma specialists are using this for all patients with multiple myeloma. The only reason I say it's evolving is because it's not everywhere. There are definitely those who do not use this for everyone, and some people only use it for high-risk patients. So I think with more studies that are currently being done and seeing the results of those, we will hopefully get some better clarity on how we should be using this very powerful treatment. Next slide, please. And this just shows, the deepening of responses over time, which was much more with Daratumumab combined with RVD. Next slide. So to summarize, induction therapy, the addition to Daratumumab to RVD results in a higher proportion of stringent CR, also increased rates of MRD negativity. What is MRD? That could be a whole 30-minute talk in and of itself, but that's minimal residual disease. And basically, this is important in people who've had no evidence of multiple myeloma after getting their initial therapy. We can use a genetic test, testing for the gene rearrangement that's found in multiple myeloma, and we can detect myeloma at a very low level. And if we don't detect it by that modality, we call that MRD negative. And so, and the reason why that matters is because there's substantial data that achieving an MRD negative response is really a very powerful prognostic sign with respect to overall survival and time to your next relapse. So it's a really important test. In my practice, I have generally used Dara RVD in high-risk patients where achievement of sustained MRD negative state is very critical, and those high-risk patients are shown here. But I think there is, again, not uniform consensus about this, even at our center. Next slide, please. So for patients who are not eligible for transplant, and I can show a slide about what eligibility looks like. We would generally use a lot of the same treatments we would use for transplant eligible patients, with the exception that we wouldn't do a transplant. For those who are older, more frail, 80s, in their 80s or 90s even, I've treated patients in their 90s, we would often consider a doublet, like Revlimid and Dex or Bortezomib and Dex, and we would use a much lower dose of dexamethasone because, as you all know, dexamethasone can often be the hardest part of myeloma therapy. Next slide, please. What about autologous stem cell transplantation? I think, I'm somewhat biased because I come from a center where we've been doing transplants for, over 4 decades. But, I think that many still feel that that transplant for myeloma remains a cornerstone of management. All of the major randomized studies have shown a benefit for progression-free survival, which is a measurement that is a rough measurement of how long someone stays in remission. I generally recommend early transplant rather than delayed transplant. And transplant, can be a toxic treatment. We're giving high dose of melphalan, which is a toxic, chemotherapy when it's given at very high doses. But we've really gotten the supportive care down very well. We, at Fred Hutch, for example, we have a whole team of people that's all they do. And it's that way at all transplant centers, in fact. And so, there are bad outcomes occasionally, but it's very, very uncommon. And all of these acute regimen toxicities are mostly manageable. Next slide, please. What kind of factors determine transplant eligibility? I think it's important to note that age is not an absolute contraindication. We have transplanted patients up to 75 at Fred Hutch, but there was a recent paper published last year, and they showed that when patients are selected appropriately, meaning they don't have a lot of comorbidities, they have a good level of fitness, transplant is just as effective for someone at 78 as it would be for someone at age 60. So I don't think that age should be an absolute contraindication. Although for most people, as we age, we have more health problems, and so that is one reason why age, it does correlate with some of those factors. Patient preference is very important. I try to always have a thorough, informed discussion with patients about, the pros and cons of transplant, the side effects. And, if someone told me they didn't want to do a transplant, that's fine. This is not a curative treatment, but it is a very effective therapy and more effective when given early. But other factors that are important: caregiver, occupation support system, and residence. Next slide, please. In the interest of time, since I only have, I think, a minute left, I will skip over this, but these were just data that still show a benefit to transplant, even with longer follow-up from the IFM study and also from the Forte study. Next slide, please. Revlimid is the standard maintenance for patients after transplant. It improves progression-free survival, and in a meta-analysis, improves overall survival. So Revlimid maintenance would just be a dose of usually 10 milligrams a day, often escalated to 15 and continued indefinitely. And it may work in part by helping the immune system recognize the cancer and keep it under control. That's one hypothesis for why this might work. Next slide. Bortezomib is another option. We have tended to prefer it for patients with high risk, although to be completely honest, these days for high-risk patients, I have shied away from Velcade maintenance on its own, but there is some literature that supports it for the del-17p or 414 translocated patients. Next slide. This is the approach that I generally take. And if you advance it, I think there's an animation here. RVD maintenance is the approach that I've generally taken. That was studied in the SWOG S1211 study. And we would generally continue RVD for 2 to 3 years and then de-escalate to Revlimid. Next slide. So I'm done. I think I only went a minute over, Kelly, so hopefully that's all right. I think it's clear that outcomes are improving for newly diagnosed multiple myeloma. And I think it's really important to consult with an MM specialist at some point. Even, we all love our community oncologists, and that's great, but they also do see everything. And so it's really important to get an MM specialist. They can see you once, they can see you a few times throughout, and just weigh in, because things are changing and you want to make sure you're getting the best treatment and taking advantage of all the drugs that we have approved that can help folks live longer. Transplant is still a really important part of treatment, and the addition of CD38 antibodies may improve outcomes. We are seeing increased rates of MRD negativity and deeper responses that tend to result in better longer-term survival. So with that, I will finish. Thank you so much for your attention and for joining us today.
Come on. That was excellent. We got in at 10:37. Thank you, Andrew. That was fantastic. Oh, and Dr. McHale texted me about the meeting. He says, hello. So I hope you'd get that there. People, that was a really, really important conversation. So you do want to take a look at the recast of that on our website at myeloma.org. Now, we got some questions here, and I'm going to read off a few, and then I'm going to talk about a few. The first one is for the doctors. My myeloma specialist mentioned that there are thoughts about stopping maintenance 3 years after the SCT. If I remain in complete remission at the 3rd year mark, what are your thoughts? Anyone want to take that? Dr. Cole?
I think, there was the Stamina trial that was really one of the largest randomized trials in the United States with multiple myeloma. And in that trial, it found that between going after transplant, going straight to Rev maintenance versus consolidation versus second transplant, that all arms were equal, and going straight to Rev maintenance was kind of the best thing, or was the easiest thing. There was a second part of that trial that was resulted, I think, last year at ASCO or ASH, I forgot which one, where there was a second part of that trial where patients were able to they're given the choice of either stopping their Rev maintenance after 3 years or continuing on longer. And the results of when people, and this is all comers, so not just people that were in CRs or complete responses, but everyone. But the patients that stopped after 3 years tended to relapse sooner than the people who stayed on. And so I think right now, I'm still recommending patients can continue on. There are other trials looking at especially MRD status in patients who are MRD negative, de-escalation of maintenance therapy in that group. But those trials take a long time to result. And so we're still gonna have to wait on that. But I would say that based on the Stamina trial, I was really hoping for that 3-year mark to kind of pan out, but I think I'd stay on.
Okay, that's Andrew, you were nodding your head a little bit there. Is there anything you'd like to add to that?
Oh, I agree. I think Dr. Cole very eloquently stated the trial results that inform our practice. And I'm in the same boat. I mean, yeah, Revlimid can be tough to tolerate, and a lot of the toxicities can be very cumulative. It may be easy in the beginning. It may not be so easy after 6 years with diarrhea and neutropenia. And so it can be tough. And so hopefully we will have, some guidance from these studies, like the Dramatic study, which is an MRD guided therapy that's run by the SWOG group, but also the Auriga trial, which is an MRD guided therapy that's sponsored by Janssen. And so I hope that these can help guide our practice better using MRD.
I'll have to tell my daughters that someone used the word eloquent in my name in the same sentence. This is recorded, right? So I could.
It's recorded. All right. A newly diagnosed patient has asked, how important is kappa lambda ratio in diagnosis and deciding treatment options? Anyone?
Well, I guess, I showed the slide about the diagnostic criteria and how if the ratio is greater than 100, we would often consider that myeloma, and, we don't have to be dogmatic about it. There are, patients who are in our clinic who that's the only thing they had, and they were diagnosed before the 2014 criteria, and they didn't want to get treated because, for example, they're an airline pilot and they would have to quit their job. And some of them didn't progress for a while. So, these are not, these are not crystal balls, but they're good tools. And I think for most patients, for the vast majority of patients, if your free light chain ratio is greater than 100, that would be, something not to ignore. And I would usually, recommend starting treatment soon after we confirm it. Of course, you would repeat it a couple of times. But what you don't want to do is play that chance of is something going to happen over the next 2 years? Because it's not like, you're following with your doctor, but it's not like they can see you every day. And I have seen people, they get seen 1 month, the next month they show up, they've got, lytic lesions, and it happened quickly. And so I think if you have this opportunity to treat, and it would be, something, usually it's something that would be beneficial, in my opinion. So the kappa lambda ratio is important. Also the absolute level of the free light chains, how high it is. If it's really, really high, that's like, for me, an emergency. I send people in the hospital and I start treatment because those patients can end up in kidney failure really quickly.
All right. I have a one from the audience. This person is dealing with the side effects of Carfilzemib. He's on, or they're on a maintenance Carfilzemib 1 day every week. And in the evening of Carfilzemib, he gets the chills, sometimes with low fever, and often lost appetite. He takes Tylenol, PETCT, Zofran as pre-meds, and additional Tylenol. The next day I'm tired, but other than that, any ideas about a better way to take Carfilzemib? Craig?
No, sometimes. I'll let Mary speak because she was just about to say something.
Oh, I didn't. I'm sorry. Mary, go ahead.
That's okay. Thank you. Yeah, I was going to jump in because I think this is described by a lot of patients, and we certainly see patients who have this reaction after Carfilzemib. I think taking Tylenol is a good thing. It sounds like the meds this person is taking is really kind of the whole boat and trying to manage most of those symptoms. So I'm not sure there's much more to add other than sometimes people benefit from a little bit of fluids with their Carfilzemib. And we often do this early when we initially start the drug. You always have to consider what the patient's cardiac status is, and you certainly don't want anyone to ever get overloaded. But sometimes a fluid bolus, even late in Carfilzemib treatment in the maintenance setting, can help with some of these symptoms. And then lastly, just recognizing that, you know, this is what's occurring every week, and it's how you feel, or every other week when you're getting your dose. And so just knowing that it's probably a part of it.
Okay, that's a great answer.
Sometimes lengthening the infusion. I've had the Carfilzemib run a bit longer, but totally, and has helped with some of the symptoms. But just like Mary said, that you know, those fluids and drinking lots of fluids when you get home can really help with that.
I have a question from the audience. I heard about mass spectrometry. Is this available now, and how does it differ from other tests? Anyone? Craig, you're smiling. Andrew, you're smiling. Who would like to take this one?
I love mass spec, and in fact, it was interesting. And what mass spec is another way to measure the M protein. And it's, you know, we've been doing this serum protein electrophoresis that Andrea talked about for, I think, 50, 60 years. And we've been doing a light chain test for, I think, 15 years. And mass spec is a super sensitive way to measure M proteins. At least here in the Midwest, Mayo Clinic does mass spec. The only place that we use it is with patients that have non-secretory myeloma, that their myeloma is so mutated that we can't pick it up on the light chain test, and sometimes the mass spec can pick it up. But it's a super sensitive way to measure M proteins.
I see. Another one for the audience. Can you talk about diffused weight MRI for monitoring disease during maintenance therapy?
Yeah, I think, really what is diffuse weight MRI? This is just one of the, techniques they can look at when they do an MRI scan. I mean, this would be a standard modality, but, I tend to prefer PET scans just because I find the information more useful. And I also find that MRI tends to not show resolution quite as quickly. And so you can see the lesions get better on MRI, but it can take sometimes, quite a long time. So I think it's fine to get, though. I'm not saying it's like, a bad modality. I personally have found PET scans to be more useful. And so I don't order many surveillance MRIs in my practice. Sometimes I might alternate. I mean, if someone's got like high-risk smoldering myeloma and they're not getting treated, I might alternate PET and MRI, because you could make a myeloma diagnosis with MRI too, and not find it on PET. But usually there's good concordance between the two.
Here's a big question. Why do you prefer Revlimid versus Velcade for maintenance, or the other way around? Craig, you're smiling.
I gotta stop smiling. There was a lot of the studies in standard risk myeloma have been using Revlimid as maintenance therapy, and it's a bit easier to take a pill. There was a study that was done a long time ago called the Cowan study that looked at high-risk myeloma and found that there was a benefit to Velcade, the proteasome inhibitors, over the IMiDs for higher risk patients. And just like Andrew had shown in his slide, that's been translated in a lot of other trials that have looked at for high-risk myeloma. using proteasome inhibitors, either as a singlet or as a doublet with Revlimid, because it's tougher to keep those high-risk patients in remissions post-transplant. And Revlimid just doesn't seem to cut the mustard as much, at least historically, as the proteasome inhibitors.
I see. You want to, let's go into some COVID stuff. I just lost the question. It was sent to me, excuse me. Is it on here, Kevin? All right, let's go to this one. Any concept or comments in the concept of remission, and does anyone agree?
I mean, I think there's good agreement about what a remission is. I mean, we reviewed all the tests, the SPep, the free light chains, the bone marrow biopsy, the PET scan. I think the one nuance can come with, the free light chains and the SPep. Sometimes after a transplant or after treatment, we might still see a detectable M protein. And it's really important, especially for the standard risk patients, don't freak out about it. It doesn't have to be 0. I have a patient who had a transplant 4 years ago. He still has an M protein of 0.1, but he has no clinical evidence of disease. So it's important, if you see that M protein, you got to look for evidence of activity, like a PET scan, and making sure they're not anemic or anything. But, kind of think of it like MGUS. We've turned this back into MGUS. And so let's just watch it. And, like I said, I've had a patient who's had this for like 4 years. I've also had patients that have gotten into CR after 3 months, and then it comes back 3 months later. So there's a lot of, as much as we think we have this figured out, there's still a lot we don't know. And just one test does not, there's not, one ring to rule them all. This is not Lord of the Rings. There's, this is a lot of nuance with these tests. And this is why you need an MM specialist, I think, frankly, because you'll have, some community oncologists will look, and I'm not trying to cast shade on community oncologists by any means, but, you look at the M protein, it's up, you're like, oh my gosh, I got to treat. It's 0.2. And it's like, no, just, hold on, stop the cavalry. Like, we gotta, let's just think about this a little bit before we just start throwing drugs at people.
Okay. All right. I found my COVID questions. So what's coming up is with this person, they're asking, what is the recommended timing in between myeloma treatments for getting the COVID vaccine booster shot while in treatment? So they've had their 2 shots, and now they're wondering when it's a good time to do the booster for myeloma. Mary, do you have anything you'd like to add to that?
Yeah, it's really impossible to give an absolute answer to these questions. I think you need to consider what type of treatment the patient is on, and then why are they on that treatment. So someone with a lot of active myeloma in treatment, it's probably not the right time to hold any of the treatment to give the third COVID vaccine, or even some of the first 2. I think we understand a little better now that Daratumumab and dexamethasone, if those can be held, patients might have a better vaccine response. But again, it is so dependent on who the person is, what the treatment they're on, and what the status of their myeloma is.
Okay, I think that handled about 5 questions for COVID. Let's go to something else here. Do all MM diagnoses show an M spike? If no, what test is used ongoing as the go-to to show progression and activity?
So I'm trying to 15% of myeloma patients their plasma cells will be so mutated that it'll forget how to make the whole antibody that Dr. Cowan had mentioned, and will only produce the light chains. And then the remainder of patients will produce, and the best test for those light chain producing patients is the serum free light chain analysis, which is just revolutionized, how we used to do things, because everybody used to do 24-hour urines prior to the light chain test coming out. Every blue moon, sometimes we're stuck with having to use the 24-hour urine Binge-Jones protein test to measure light chain patients. And then there are the remainder of the patients that will produce a heavy chain, an IgG, IgA, rarely IgM or IgD. And for that, the SPep, the serum protein electrophoresis, can define the disease. And the higher the number of plasma cells in the marrow, the higher the light chains are in protein. As you do treatment, the number of plasma cells fall, and so those proteins fall. 1% of patients will produce nothing at all. They'll be asecretory. That sometimes you can pick up something on that mass spec test we talked about. I think Dr. Cowan had mentioned sometimes we can use PET scans and other indirect measurements to see how those patients, how their disease is going. But I think the toughest kind of measurement of disease are the patients that have asecretory myeloma.
And with that, we'll end this question and answering segment. All right, all you people out there in webinar land, put your pencil down and do a hand clap. Thank you, Andrew. That was fantastic. Thanks, Craig and Mary, for getting a question in there too.